Welcome to another episode of Living with FASD. I'm your host, Patti Kasper, and this week's candid conversation is with Dr. Jeffrey Wozniak, who is a researcher out of University of Minnesota, and I can't think of a better way of celebrating both International FASD Awareness Month and tomorrow, which is International FASD Awareness Day. So stay tuned, buckle up, and enjoy this candid conversation. Welcome, Dr. Wozniak.
Thank you very much. Great to be here.
Yeah, so you are at University of Minnesota, is that correct?
Yes, so I've been at the University of Minnesota since 1996, first as a trainee, an advanced trainee, and then as a faculty member since 1999.
Okay, they must treat you well if you've stuck around that long.
Of course, of course.
Right? So University of Minnesota is, tied in rather closely with the FASD community. What all do you have going on up there?
Yeah, we have had a clinic at the University of Minnesota since before my time. So there were a couple of people in the med school who founded a fetal alcohol spectrum disorders clinic back in the 70s, not that long after the condition was first described.
Yeah.
And I wasn't here for that early history, but my understanding is that these were pediatric genetics folks who were interested in neurodevelopment and started a clinic. There was a psychologist who was involved early on who I knew when I came to do my training. And then there was a kickstart kind of given to the emphasis on fetal alcohol spectrum disorders by Susan Carlson,
Mhm.
who at the time was juvenile court, worked in the juvenile court system, and was married to Arnie Carlson, who was the governor of Minnesota. So she had opportunities to observe, what the needs were for kids with FASDs, and she helped found the local chapter of the National Organization on Fetal Alcohol Syndrome at the time, which was called MOFAS, or the Minnesota Organization on Fetal Alcohol Syndrome. They're now called Proof Alliance as part of their rebranding. So that we've had a lot going on at the University of Minnesota around FASD for many years. When I first started as a clinical psychology trainee, I started to work with some patients in the clinic and had no, after 5 years of graduate school, essentially, and 4 years of undergraduate in psychology, had no training, no knowledge of FASD whatsoever.
So what attracted you to learn about it?
Yeah, I think it was driven by working with the patients in the clinic and seeing kind of the variety of issues that folks with FASD deal with on a day-to-day basis. And it's an interesting condition from a neuropsychological perspective. So my background is in neuropsychology, which is the study of brain behavior relationships. And clinically, we try to understand what are the unique needs and strengths and weaknesses of a person with an FASD. So I found that fascinating, found the families really interesting. Very early on in my career, worked with some really remarkable sets of parents who, were raising 15, 16 children, with special needs across the years, and really was struck by kind of the commitments of families who were working with FASDs and their kids.
Okay. So have you always worked primarily with youth, or do you work with adults also?
Yeah, I'm a child and adolescent neuropsychologist, so I work
Yeah.
almost exclusively with kids and adolescents. Occasionally, I'll see some young adults who, we've been following for a number of years, and we follow them into the early adulthood years. Adulthood doesn't start at 18, of course, as we all
Right.
know. When does it really start? I'm 50 something, and I'm not sure that I've reached the full adult capacity yet.
Oh, wait,
So
wait
I
a
do.
minute now. You're kind of teasing that adulthood means boredom.
No, adulthood definitely does not equal boredom. So yeah, I see people into their early 20s occasionally if we've been following them for a neurodevelopmental condition.
Okay. So what I'm curious about the current research that's going on at U Minnesota.
Yeah, happy to talk about that. We have had for many years an interest in brain imaging. So we have a fantastic brain imaging center here that's really driven by the physicists and the scientists who developed the hardware of the MRI. And as a result, we have a lot of expertise in how to image the brain in very exquisite detail.
Mm-hmm.
And so we've been able to take advantage of that with our research that's kind of clinically focused or driven by an interest in a condition like FASD, take advantage of all of this expertise that we have here to do brain imaging. So we've been doing that part of the research for more than 15 years, probably almost 20 years now.
Mm-hmm.
And that has given us a lot of insights into the variety of effects that prenatal alcohol has on the developing brain. So that's one piece, and we can
Mm-hmm.
talk more about that. We've also become very interested in interventions. So after many years of doing studies, trying to understand what has gone wrong in the brain during development and how that affects a person's performance on, memory tasks and learning and their ability to regulate their behavior, we wanted to try to do something about it. And this was when I first started that work. We kind of thought of neurodevelopmental conditions as static, or,
Mm-hmm.
kind of the injury was done. In this
Yeah.
case, we sort of thought the changes to the brain were done and in the prenatal stage. And we just had to find ways to accommodate to it. But, the field has shifted a little bit to trying to push and see if we can do something about these early insults that have happened. And we have a strong developmental focus at the University of Minnesota. We have an Institute on Child Development that's kind of a world-renowned institute. So I've been influenced by some of their thinking about the power of development, that
Mm-hmm.
development is an energetic, ongoing, continuous process,
Yeah.
and that nudging it one way or another through various means might be a very powerful strategy to try to
Mm-hmm.
overcome some of the early things that happen to people.
I,
So we
I'm
first, yeah, go ahead.
I'm curious. I've read some studies about the use of choline. Would that
Right.
tie into what you're talking about in
It's exactly,
supplementation?
yeah, it's exactly what I'm talking about. And it's a good example of kind of a test case for this idea that, if you ask the question, how can we influence early development
Mm-hmm.
and take advantage of all of that development that's going to happen anyway, regardless of any early insult? How do we take advantage of that and push it in one direction?
Mm-hmm.
So choline is a single nutrient, a micronutrient that, we all consume in our food, and our bodies can produce some choline, but we need to consume some. So in that way, it's kind of like a vitamin. It is not a drug, but it has effects on brain development. And it, and we can kind of go into some detail depending on how fine-grained you want to get, but it has a lot to do with the construction of the brain and the function of the brain at these very early stages. So we started to give supplemental choline to kids as early as age 2 and all the way up through age 5. And then we measure the outcome in terms of memory specifically, because memory is driven by some regions of the brain that are actively growing in a very fast way during that
Yeah.
0 to 4 year period. You always hear about how important the first year of life is and how important the first 3 years are. Um, in this case, we're talking really about the first 3 to 4 years, probably, for this one part of brain development that we're really thinking is important for memory.
Yeah.
And so we started to supplement kids as early as 2. And we do this for a long period. We do this for 9 months.
Mm-hmm.
So think about a 2-year-old and you're supplementing something for 9 months. That's, essentially a third of their life by the time you finish a 9-month
Yeah.
study. It's a substantial opportunity to interact there with the ongoing brain development. And what we've seen in those studies is that choline has the ability to optimize, to some extent, certain types of very specific memory,
Mm-hmm.
sequential memory, for example, memory that requires linking things together in time.
And those are definitely things that we struggle with.
Hmm.
Yeah. Yeah.
Yeah. And
You're saying that the peak growth period for those regions of the brain is, 3 to 5 years old? Is that why we don't really read about studies in choline being given in late childhood, adolescence, adulthood?
yes, that there are, it's because of that growth spurt that's happening during those,
Mhm.
0 to 3 or 4 year time period, maybe into 5. We pushed it into the 5 year because we
Mhm.
weren't sure and we wanted to see. What we did see in our data is that earlier is better.
Yeah,
And there are a couple of other groups that have studied prenatal supplementation. So we've
yeah, I've read
always
that too.
supplemented the kids. Yeah. So the idea there is that if you get to the developing brain even earlier during
Mhm.
the prenatal period, you have even more of an impact. And so those studies are still ongoing, but the data
Mhm.
that have been published out of those studies also show some benefits of choline. These are small benefits. So,
Yeah,
we're not fixing the brain, we're not
right.
completely reversing things, but we're trying to optimize the development that we have left is
Yeah,
the
it's
concept.
definitely mitigating it. One thing that I was curious about as I was listening, initially why I asked the previous question was the lay of the land survey, the first one on the 428 comorbid conditions. Um, we have a 206-fold increased risk of early onset dementia. And, one of the things that FASD and dementia have in common are memory issues. And so I couldn't help but wondering, I wonder if choline could be useful to offset maybe that transition.
Let me say two things about that. One, I would like to be optimistic about the adult and later adult years of folks who have FASDs. And I would caution a little bit about interpreting
Mhm.
what you just cited, that there's this dramatically increased risk of Alzheimer's. Those are survey data, so we have to
Right,
be really careful about understanding, answering a question, yes, I have memory problems, is different than a formal study where someone undergoes cognitive
right.
testing and maybe a PET scan or something to diagnose Alzheimer's. So we have to be careful about that part. And then we also have to be careful about what we call acquisition bias, which is who's responding to the survey and how are they
Mhm.
responding. It's not a random group who responds to the surveys, right? It's people who are interested in the phenomena that you're studying.
Mhm.
So what you tend to get is elevated rates of, let's say, problems with memory on surveys like that. So what I don't want is for people with FASDs to feel afraid that they're
Mhm.
going to develop dementia. We have very little data on that right now. And
That's one of the two areas of research I would love to see. Just picking two of those 428, I would love to see ones that are near and dear to my heart. And dementia is one of those. I care for my mom who is Lewy body.
mm, yeah,
And, the survey doesn't distinguish which type of dementia. It's just early onset of that whole umbrella of conditions, because there's hundreds of kinds of dementia.
right.
But as I contemplated that, I couldn't help but observe that there's a lot of similarities between FASD and Lewy, for instance, and this is definitely not causal, but they are both the most highly misdiagnosed condition of developmental disorders versus dementia disorders. Lewy body is the second most common form of dementia, but it's the single most misdiagnosed. The intermittent on again, off again nature of all the symptoms is another one. And show timing, of course. Well, they call it show timing in dementia circles. We just call it masking in the neurodivergent space. But yeah, I would love to see somebody tease that out.
Hmm.
Yeah.
Yeah, and I would say theoretically, we don't have a lot of understanding of how there would be a connection between prenatal alcohol exposure and something like Lewy body dementia,
Mhm.
that's a big leap in terms of like the physiology
Yeah,
and the chemistry that would be involved there and
yeah.
just the number of years. But I think, these are starting points to
Mhm.
understanding where the elevations of certain conditions might be and why that might be. And then there's a lot of steps in between, right? Folks with
Mhm.
FASDs have other things that are different about their lifestyles over the course of those,
Yeah,
60, 70, 80 years that would potentially also be contributing to the development of a condition
yeah,
like that.
absolutely.
So again, what I don't want people to do is to fear for
Mhm.
themselves that because they have an FASD, they're going to develop dementia. That
Right,
is
right.
uh, there's too many other things
That's
to
too big
in
a
life
leap.
to be concerned about, and
Yeah,
and
yeah,
and I would not make that stretch. Yeah,
right. Kind of like getting all paranoid that I'm gonna die by the time I'm 34, based on that one or survey result that keeps coming up on Google, when you ask
right.
the question.
Yeah, please be skeptical of those types of things.
Yeah, yeah. Well, because the context is never spelled out in the articles that pop up, not in a way that the average person would be able to pick up anyway. So I'm also very curious. I would love to see further research with the relationship between FASD and type 1
Hmm.
diabetes.
Hmm.
And again, as of now, it's just correlational. It's just a comorbidity. But, and I've said this on the show before, in my particular case, I think we're starting to see information come out through research that might indicate in some cases it might be causal. And I believe in my case it is. When I was when I was doing the research on the second edition of my book, some research that said the five structures for insulin signaling production come online in the first month. And in my case, my mom drank every day of the whole pregnancy. It was the 60s. Nobody knew any better. I was diagnosed at such a young age, and there were no illnesses, no other traditional triggers for it. So I really think in that case that was the reason. But I would love to see it teased out because we see both conditions ticking up in prevalence.
Hmm.
And I think, that really strengthens the reason to try and heighten our prevention work,
Right,
because they're both very expensive conditions to live with.
for sure. Yeah.
Yeah.
I think if you haven't had Claire Coles or Julie Cable or Susan Stoner on, there are some other folks who are doing this more survey work in
Hmm.
in adults with FASDs right now and are also seeing some of these elevated rates of, let's say, metabolic conditions.
Yeah.
We know, for example, that obesity is is a risk for individuals who have FASDs, especially female. There's a little
Hmm.
bit of a difference in terms of male female, the growth trajectories and likelihood of obesity. So obviously that's a factor in some of these metabolic conditions as well.
Hmm.
So we're
Hmm.
starting to learn about that, and I think there are data already coming out from the work that those folks are doing that I think
Okay.
are going to be pretty interesting. And then there's a whole group of scientists who are studying animal models and looking at, let's say, the metabolic effects of prenatal alcohol exposure and showing, yes, that there are effects on
Hmm.
metabolism. We know there are effects on immune function, et cetera. How that translates to humans is still yet to be determined, but
Yeah.
the pieces are being pulled together.
Yeah. Yeah. I'm friends with somebody who was never a drinker and yet has advanced liver disease because of the prenatal, which is it's just fascinating everything that can spill out from, I mean, how broad the range of effects are. What are some of the things that you're interested in pursuing or having the university pursue further?
Yeah. We are currently working on something we call neuromodulation, and that is essentially stimulating the brain, in this case through the scalp. And so there are a number of ways within the last 15 10-ish years where there's technology to be able to deliver an electrical signal to the brain rather than just reading what's happening in the
Mhm.
brain. We can actually deliver signal. And there are different ways to do this. You can do this with a big magnet. You can do this with electrodes that you place on the scalp, and then you deliver microvolts through the scalp. That's the technique we're using. And the concept is that the brain, it learns and it makes connections when information is being processed. And so what we're doing with this electrical stimulation is, for example, in a teenager, we would have them sitting at a computer working on a game that is challenging their memory or their attention or their executive functioning. And then we're stimulating part of the brain that is associated with that process. And the idea is that the stimulation tells the cells, it lowers the threshold for those cells to fire. So they're firing a little bit more, and
Okay.
when they fire, they make a connection based on what's happening in that person's thinking at the moment.
Mhm.
So it's a very small amount of current, almost really not even something that you feel. And we do repeated sessions. So right now we're doing a 10 session study with teenagers, school age kids and teenagers.
Mhm.
And we do about 45 minutes of that. And then the tasks that they're doing get progressively harder over those 10 sessions. So
Mhm.
they're improving at the cognitive skill, whatever it is, memory or paying attention or sorting things or
Mhm.
remembering where things are in space. And then we're giving the stimulation at the same time. So that's one area that we're particularly interested in developing another treatment. This would be for older kids because we talked about how the choline is really
Yeah.
targeting a much younger age range. And this would be something that would be applicable really across the lifespan. There would be no upper limit to this
Mhm.
type of an intervention.
Okay. And that does sound like it might be promising.
Yeah,
So,
I think we're seeing some effects there in very specific areas like concentration. And it's partly due to where we're stimulating and the types of training that we're doing. So we might be able to enhance that. And then, that would be highly tailorable. So you can design the games differently for different effects that you're trying to address. You can design them differently for different age ranges. You could
okay.
design them differently, with different stimulation patterns to try to improve a different set of cognitive functions.
So
That's the idea.
to tailor that for the individual patient, then you would need I'm assuming, a battery of assessments to find their academic strengths and challenges.
Yeah, yeah, that's exactly what we would ultimately do with this. Right now, we are basically testing it. So we're giving it to a group that we think has executive functioning impairments. So
Mhm.
we're not necessarily doing all of the tailoring just yet. We have to kind of have one standard thing that we can test first.
Right.
And then, yeah, then the idea would be that we would expand it.
That and then we would of course need to really multiply the number of providers who would want to get into that kind of work.
Right.
And
Yeah.
that might be more challenging than anything else.
Yes. One of the cool things about this idea, though, is that it can be quite portable. So
Yeah.
we're actually doing in that study, 7 out of the 10 sessions are done in the patient's home
Oh,
remotely.
that's
So
wonderful.
we do an initial session with an MRI scan in the
Mhm.
office, then
Yeah.
we send people home and they have a remote device that they wear. It's like a headband,
Yeah.
and we administer the sessions remotely on Zoom, just like this.
Oh, that's
And that would allow us to really get it out to rural communities and,
yes.
places where people don't have access to specialized healthcare.
That is really exciting. That
Yeah.
is really, really exciting. I'm wondering if you see any hurdles to this potential treatment from like insurances or, all these systems that are slow to embrace FASD as a developmental disorder.
Yeah, it's a good question. Um, I think with something like this, generally what you need is evidence. for
Hmm.
the insurance companies to take it seriously.
Yeah.
And insurance companies are, really in the business of serving their base, right? They want their people who are paying for healthcare to be getting high quality healthcare. So,
Hmm.
some of the picking and choosing about what insurance companies do is based on evidence. They want to see evidence that the therapy, the treatment, the intervention, the surgery, whatever it is actually beneficial, not just, speculative, but actually there's data to show that it's
Right.
beneficial. So that's what we would be doing with this kind of research is generating that evidence, publishing it, and then,
Yeah.
it would be shareable with insurance companies to say, here, look, do this pay for this because these are the outcomes that you're going to get from that.
Yeah.
That then incentivizes clinicians to pick it up if it's something that they know is going to be reimbursable and it's going to be efficacious for their patients or clients.
Yeah. That sounds really, really promising. I'll be excited to follow that.
Yeah.
Um,
And along those lines, maybe I'll just mention we're doing another remote study right now with a colleague of mine, Blake Gimbel, who's at the Ohio State University and Nationwide Children's Hospital, and Sarah Matson, who's in San Diego at San Diego State University,
mhm.
who's a big FASD
Yeah.
researcher that I'm sure you
Yeah.
know. So we're doing this collaborative study trying to use Sarah's remote neuropsych assessment tool. One of the other issues that you might be aware of is that getting a diagnosis for FASD is tricky. There aren't that many clinicians who do FASD diagnosis. There aren't that many centers who have the ability to have a neuropsychologist and a dysmorphologist and a
Yeah.
pediatrician.
Yeah,
So,
it's hard enough for children, but for adults that come that hear about it and realize, oh, that's describing me, it's even harder to
mhm.
access. Yeah.
Yeah, adults are extremely it's extremely challenging to get diagnoses, and it has to do with this sort of bifurcation in the way that people clinicians go. They either train in child and adolescent work, whether it's psychology, psychiatry, pediatrics, or they go into an adult related field. And so the training ends up that people who are interested in neurodevelopmental conditions are all in the
Right.
child-oriented camp, and
Right.
the folks who have, more of an adult practice are very, very much less familiar and have less interest in evaluating neurodevelopmental conditions. So
Yeah.
a tool like this, that we're describing here could potentially be useful to do some specific and some initial work up with a patient to see what the level of deficits might be. So
Mhm.
we're testing it. It's about a 30 to 40 minute at home neuropsych screening takes place on a, screen, a computer
Mhm.
screen, a laptop screen. And then what we're doing with this study is we're collecting this data from people who have had a recent neuropsych evaluation, a full-blown in-person
Mhm.
neuropsych evaluation, so that we can then compare the two and validate the test and see how well it
Yeah.
works and what needs to be tweaked or adjusted about it to make it more valid.
Do you have any preliminary findings yet?
We don't. We're still in the middle of collecting that data. In fact, we need people. So, if anyone is interested in participating, there's a small payment for being part of it. And really, what we're looking for is people who've had an evaluation within the last year or are going to have an evaluation within the upcoming year, a neuropsych evaluation or some cognitive testing.
Okay.
And it's about a 30 to 45 minute thing that we guide the person through. It's for
Okay.
ages 8 to 16.
If you can
Um,
get me a link, then I will put that in the show notes because it
yeah,
sounds like a definite call to action for the audience.
yeah,
So,
we would love to hear from people. I'll give you the link. It can be found on our website at fasd.edu, and that's UMN like University of Minnesota.edu. But I will send you that link as well.
awesome. Okay. We'll see if we can't get you some subjects.
That'd be fantastic.
Yeah.
We would love to hear from your audience.
Yeah. Yeah, I love to promote new books that are coming out, to promote research studies that are seeking people. So, yeah, I'm all about that. Yeah, that sounds fantastic. So, yeah, one of the, my interest shifted from kids and families. That's how I got into this work because I was a foster care and adoption social worker for 25 years in California. And I wanted to find out why the kids were falling between the cracks and, bouncing from home to home to home to home, and why parents were not adequately trained to work with
Mm,
them and stick with them and, deal with all the chaos and, manage and giving up, which is just really sad to see. But the more I learned about it, I actually recognized myself.
mm,
And so I asked my mom, "Did you drink?" She's like, "Oh, yeah, every day." With,
mm,
with
mm,
such surprise in her voice, like, who doesn't? And, like I said before, it was the early 60s. Nobody knew any better. And then I got to, when I was doing some of the research, even for the first edition of Sip by Sip, I looked at the stats. There was a quote, and I can't even think of the research group off the top of my head, but one of the quotes for the article I was reading was that we owe a debt of gratitude basically to the 99.9% of people with FASD who are undiagnosed.
mm,
And if you apply that to the population stats for the country, that means there's like close to 15 million adults wandering around who don't understand that their quirks and their struggles and their challenges are the result of prenatal brain injury.
mhm.
And that really shifted everything. So it changed me professionally as well as personally. And that's why I kind of ask, that's why this show is geared more for those of us who are living with the condition. Although I'm certainly beyond happy when parents find hope and, things that will benefit their parenting. So that's why I ask some of the questions that I do. And that's why I'm so passionate about, I wishing there were more resources for diagnostic capacity for adults.
Yeah.
So,
Yeah, I hope that the work that we're doing with this tool will lead to some improvements in
yeah.
the diagnosis. There's some other work going on. I'm part of a consortium or a large group of researchers called CFAST, which
Mhm.
is the Collaborative Initiative on FASD. And so part of one of the groups within that larger group is studying 3D technology, cameras, and image processing of facial images in order
Mhm.
to help with the diagnosis when there are facial features, sometimes very subtle facial features. We're using tools in the brain, with the brain MRI to try to pick out individuals who we think the brain looks substantially different enough to be
Mhm.
able to say that there's something there that was probably caused by prenatal alcohol. So, on different fronts, we're kind of working toward making the diagnosis easier.
Yeah.
And then there's a lot of folks who are pushing on the training side, to try to train pediatricians and to
Mhm.
try to train, you know, non-specialists to do these evaluations and
Yeah.
recognize people.
Yeah. Yeah.
So,
My self-identification was formalized last summer as NDPA by an SLP that was
mhm.
doing a multidisciplinary approach. But there's not many centers that do that. And this technique that you're describing, that sounds like it could easily jump to the adult population.
Right. Yeah, I think it could. Yeah.
Yeah. And that could help so much. So,
Yeah.
one of the things that I'm frustrated by, but I can understand it, is when a clinician will say, well, coming from adoption and foster care, you don't have the documentation of PAE for most of the kids, and especially kids whose birth parents have just really dropped out of the picture completely. What do you do with that? How do you get it? You can go on the assumption that, there's such a high percentage of kids in the system that are affected by alcohol, but a lot of clinicians will say, well, we'll call it autism or we'll call it ADHD because it looks like that too. And at least that way they can get services. And that's all well and good for accessing services any way you can, but
Mhm.
it's not a complete picture. And I think part of the complete picture is knowing that you have an increased risk for all these other physical conditions, because I think that can really help when, as things physically develop with you later on in life, you have to go through a differential diagnosis to figure out
Mhm.
what's going on with somebody. And just that information might make a difference.
Yeah, I think those are all very, very good points. Some of the trickiness with this has to do with what you described, that we oftentimes don't have the information in the
Mhm.
initial records. A child's medical record. Now we have everything is electronic medical records these days,
Mhm.
and it's very good at keeping data forever. But we have a basic disconnection between what's in the baby's record or the child's record and the mother. Those are two separate things, and
Right.
they
Right.
oftentimes don't cross for a lot of reasons. There's some, obviously privacy reasons, but also just the fact that they're two individuals, and
Mhm.
the linkage between those two things is often broken. So uh, yeah, we don't know. As you've said before during this conversation, we just don't know how many people have been affected, and that limits us in terms of identifying those individuals, but also, how much emphasis we place on public health policies and on other
Yeah.
sorts of things when we just don't know the true numbers.
Yeah. So if universal drug testing has been implemented at the time of birth, right? Because that's how so many kids end up in the system. What about one of the things that I stumbled upon when I was prepping for the second edition of my book was the umbilical cord tissue will hold alcohol for 20 weeks. That's 4 months because there's no way to metabolize it. Do you think there could potentially be a future for universal umbilical cord testing?
Mm.
Not for
Uh,
punitive purposes, right? But just so
yeah,
that services can be put in place early, immediately.
yeah.
Like immediately do that choline supplementation.
Right. Yeah, that's an interesting thought. There are some technical challenges. I'm aware of some researchers who have tried to determine alcohol exposure through, blood spots from the newborn, through cord blood, through various other methods, through hair, the
Mhm.
infant's hair, and they all vary in their technical accuracy and kind of technical challenges around them. And then you have the ethical challenges of how, if you're going to implement something like that, you have to overcome a lot of ethical issues about
Mhm.
who has the right to privacy, who gets that data. It's a complicated kind of
Yeah,
medical legal decision-making process, to say the
yeah.
least.
I don't think it's insurmountable because we've made that leap with, when testing for heroin or cocaine or marijuana and all those other things that are routinely part of the birth process in hospitals.
Yeah.
I just think stressing because it is an ethical thing, stressing that it's not for punitive purposes, but it's to ensure that the baby gets every advantage possible.
Yeah, I think it's a good point. And what we need there probably is more research too, to show like what is the benefit, right? What's the
Mhm.
actual benefit of knowing that information if you're going to do, let's say, nutritional supplementation, really having clear information about who benefits when you get
Mhm.
that information then helps you make those ethical decisions, right? Because an
Mhm.
ethical decision is always a balancing of weighing the positives and the risks. So
Yeah,
I think we need some more research to understand that, and then you would probably have a lot of discussion about how to implement it too. But I
yeah,
think it's a
yeah.
very interesting idea.
Yeah, and I think part of, maybe another service that could be put into place if there was. alcohol in the cord tissue, might be education around, what alcohol does to both parents, since we know that you can get effects through the semen as well, even if it's not the full FASD. But education around that, education around, it passes through the milk as well. My mom used to wonder why I always fell asleep while I was feeding. I don't know, Mom.
Yeah.
Maybe because it
Yeah.
was cocktail hour.
Yeah, you're right. We do know that it's passed in breastfeeding. We're now learning more about the father's drinking as a contributing factor to
Yeah.
development generally and to cognitive development. So, and we're learning about the effects of alcohol on the body as a whole as
Mhm.
well, long term. So, we now have good data about alcohol and cancer,
Yeah.
certainly alcohol and various liver conditions,
Mhm.
alcohol and brain function in the later years. So there's a lot of evidence to suggest that, we really ought to be more aware of alcohol's
Yeah.
effects on the entire body. And that includes the pregnancy, obviously, too.
Yeah. I think there's such a misplaced emphasis on alcohol spilling out into behavior, into children's behavior, but it is so much more than just that. So, I was fortunate. I was never one of those behaviorally challenged kids. Um, and intellectually, I was always in the gifted range, but I did struggle with executive function, and and I've had my challenges. Like so many of us, I've got a lot of the ADHD symptoms, and
Hmm.
that brings its own set of challenges.
Hmm.
Squirrel.
But also superpowers, right? I'm sure you're aware of
Yes.
all of
Yeah.
the special qualities that people with ADHD and executive functioning problems can have
Yeah.
to compensate, right?
Yeah. Yeah. A lot of outside the box thinking.
Hmm.
So.
Hmm.
Jeff, I'm so glad that you joined me for this time on Living with FASD. It's been just a remarkable, fascinating conversation, and I'm so grateful for it.
Well,
So,
I appreciated the invite, and I'm happy to be here, Patty. I hope this is useful to your audience, and I hope people take a look at some of the research we're doing and participate if they want to, but mostly just learn from what we're doing.
yeah. So again, let's summarize that. You're looking for people 8 to 16 years old. So parents who are listening, if this is your kid, then get ready to click the link in the show notes. 8 to 16,
Who have had a recent
recent
evaluation within the
neuropsych
last
workup.
year,
Okay.
or have one upcoming within the next year.
Okay.
And then the task would be to get on Zoom with us,
Mhm.
run through a little bit of consent process, and then do about a 30 to 40 minute at home neuropsych screening, testing reaction
Okay.
time, memory, attention, those types of things.
Awesome. I think that will be fantastic. I hope you get a lot of interest from the audience. So thank you so much for your time today.
All right. Thank you for doing the work you're doing and sharing all this wonderful information with your audience.
Oh, it's my pleasure. Thank you for tuning in to Living with FASD again this week. I hope you've enjoyed the program with Dr. Jeffrey Wozniak of University of Minnesota. If you are a parent of a child ages 8 to 16 and your child has had a neuropsych assessment within the past year or has one coming up, then please check the show notes to get the link for this research that Dr. Wozniak was talking about in this week's episode. I know we would all benefit from your participation. Thank you for bearing with me as I have not been putting the episodes out as frequently due to some medical issues as I recuperate from various surgeries. Just thank you for keeping me lifted up in your thoughts and prayers as well. I hope you have found today valuable. Thank you for listening. Take care.